Thank you very much to Campbell and to Vicky for inviting me. I'm a gastroenterologist just down the road, and I'm going to talk about fatty liver. So for those of you that aren't used to looking at ultrasounds, this is the ultrasound of a liver, which has a lot of fat in it, hence the title of the talk. So we're going to talk just a little bit around non-alcoholic fatty liver disease, how it fits into today, and how it's one aspect of one of the gastroenterological problems that I deal with as a result of the issues that we currently have with the size and shape of our population. But I do have a little bonus at the end, which I'm going to share with you as well. So, fatty liver, what is it? So, you already know from the other speakers that fatty liver is part of the metabolic syndrome. It often is a bit of a Cinderella one, because obviously nothing's very sexy about the liver. People try not to think about their liver. And in fact, there are two common causes of fatty liver, one of which we'd all rather not think about if we can, which is alcoholic liver disease. Now, to make the differentiation between alcoholic and non-alcoholic liver disease, we tend to say in Taunton that if you're drinking more than 25 units a week, then that makes you much more prone to the fat being related to alcoholic liver disease rather than non-alcoholic liver disease. Now, 25 units, to put that in context, is 5 half bottles of wine with 2 alcohol-free nights. And you think about the population and how much they drink, that's quite a lot of people. So while we have a big problem with this, we also have a little problem with this. So concentrating on the non-alcoholic fatty liver, it tends to be more men, but women have a higher risk of fibrosis. It tends to be those who are diabetic, obese, increased waist circumference, increased insulin resistance, goes up with age, high fructose intake, high blood pressure. So it's very much the same bunch of patients that we're already talking about. The thing about fatty liver is it doesn't have very many symptoms. People might feel a bit tired, but lots of people feel tired for a whole variety of reasons in our population. Occasionally they might get right upper quadrant discomfort, which might be what led them to the ultrasound, which showed the bright liver in the first place. So why is the incidence of fatty liver rising? And there's no doubt that it is. I think things probably started to go wrong in about 1980. So what else happened in 1980? So there was assassination of John Lennon. Nothing to do with that, clearly. Invention of Post-it notes. But there was also the release of these guidelines in America, Nutrition and Your Health. And I tried to cut and paste them from the internet. I think the biggest problem is that this was the point where guidelines started to demonize fat, saturated fat and cholesterol. So it's from these guidelines that we started to get some of our advice that we're all following today. And also the advice to eat foods with adequate starch and fibre. So these things started to be produced. These same guidelines, to be fair, do say avoid sugars, but actually you're clearly having sugars here, but not realising it. So this is probably the start of when the problem started to occur. And we all know when we look at population data that 1980 was about when obesity really started to take off. I've talked a little bit about fructose already. It's a problem with non-alcoholic fatty liver disease. And the reason it's a problem is because we're just starting to eat an awful lot more of it. So in naturally occurring fruit and vegetables, it's probably 5 to 10% by weight in things like apples, probably a bit less in blueberries. But there's very little in milk, meat, veg. In the early 1900s, average Americans ate just 15 grams of fructose a day. It's now closer to 60 or 70. And just to show you how diet changes, fructose is 50% by weight of dried fruits. So where fructose comes from sucrose, which is broken down as a molecule of glucose and a molecule of fructose, but there's also a lot of it in high fructose corn syrup, which is something you'll see if you look at packets. There's an awful lot of this around because it's a very easy way of adding sweetness to things, and that's 55% fructose. So a lot of drinks will contain this. Coca-Cola started adding it in 1980 instead of sucrose, and it's in a lot of highly processed foods. Glucose is regulated so that when energy levels are high in the body, that limits hepatic uptake of dietary glucose, which essentially acts as a brake. However, fructose doesn't have such a regulatory mechanism. It's independent of energy status. So no matter how much fructose and what the energy level is in your bloodstream and in your body, there is nothing that regulates its uptake. So actually that increases lipogenesis, which makes fatty molecules, which then turn into fatty liver disease. And this is a little bit about why we think it's important. So that's a normal looking liver. We know a third of the population, so about 30 to 40%, will have a fatty liver. So this is a non-alcoholic fatty liver disease. It's highly associated with these conditions, so dyslipidemia, insulin resistance, obesity, metabolic syndrome, type 2, all the things we've talked about. So fatty liver is the thing we pick up in ultrasound scans where the liver looks bright. Now we know that 5 to 10% of these people will go on and get NASH, and this is where it starts to get worrying. So this is non-alcoholic steatohepatitis, which is the effect of this condition causing an upset and inflammation, as has been talked about by one of the previous speakers. So that's associated with a whole heap of metabolic problems, including oxidative stress, which creates free radicals, apoptosis is breakdown of cells, increase in the pro-inflammatory cytokines, which Peter talked about, and they cause damage to the liver to make this non-alcoholic steatohepatitis. We know a percentage of these patients will go further and develop a condition called cirrhosis, which is end-stage damage to the liver disease. And we know that about 3 to 26%, depending on which study, of this 5 to 10% will get cirrhosis. So we really need to stop this here, and preferably we need to stop it here. We know that this is important because NASH, so that the third liver along, progressing to cirrhosis, there's a 10-year mortality associated. The 10-year mortality is 20%. 45% of them will decompensate their livers, which for those of you who aren't medical, that means they'll turn yellow, they'll develop edema in their legs, they're at risk of bleeding disorders, and essentially are pretty sick. 2.6 will end per year will get hepatocellular carcinoma, there's the increased cardiovascular risk, and it's also the second highest indication for liver transplant. So how do we actually manage to pick up the ones that we need to pick up at an early stage and do something about it? So it doesn't always depend on things like age, gender, body mass index particularly, and percentage body fat. So of these two, one is a toffee, which is thin on the outside and fat on the inside, which is this one on the left, and one is a FOTI, so fat on the outside, but thin on the inside. So this is the much riskier profile because you've got fat in your liver here, you've got visceral fat around your internal organs, and this is the one that leads to the metabolic syndrome and insulin resistance. So we diagnose it on the basis of ultrasound. We exclude with other blood tests. We know that liver blood tests can be normal in a high percentage of patients that still have non-alcoholic fatty liver disease, and the liver blood tests tend to normalize as fibrosis gets worse. So as fibrous tissue starts to develop in the liver, we know that the blood tests don't correlate with the severity, which is very worrying. The clues are those who are centrally obese and diabetic, and we know that there are certain changes within liver biopsy, but because liver biopsies are risky, with a 1 in 10,000 mortality and a 1 in 1,000 risk of complications, we try and avoid them, so we try and think about alternative tests so we can pick up that group, just going back a couple of slides, who are here, and try and prevent this happening by putting our intervention in. For those who are GPs here, you already have access to this, which is the non-alcoholic fatty liver disease fibrosis score. So you plug in things such as age, body mass index, whether they're diabetic, a couple of blood tests, and that calculates a score. And a score of a certain level or above puts them at increased risk of fibrosis, so they're the group to concentrate on. Similarly, we've got a couple of other things coming. So there's more specialist liver blood tests, which you will be able to order, and we've also got a FibroScan, which is quite a nice thing to do. It works well when patients aren't too obese, and what happens is the patient has an ultrasound scan with our specialist nurses, and we have a machine that literally says ping as it's doing the reading, which again, nice for patient involvement. And what that does is to give us a number, which again gives the likelihood that the liver has progressed beyond a certain stage. So for those people, so we need to identify patients, we need to risk stratify them. Are they those low-risk non-alcoholic fatty liver diseases of the second liver, or have they progressed to liver 3 or liver 4? Clearly, we need to know about liver 3 and liver 4, but liver 2 needs an awful lot of intervention. So those interventions are here. We've talked about these already. So lifestyle modification, we need to target the metabolic syndrome. Other people have covered that far more effectively than I could. There is some liver-directed pharmacotherapy. So this is chucking jugs at it, which again is never great really. If you can do it with lifestyle, it's far better. And obviously we need to screen for the complications of cirrhosis, which I've not really concentrated on in this talk. This is a probably now fairly politically incorrect poster from 1980, which kind of says everything we knew about managing these sorts of patients. But again, typical size and shape of one of our patients. And this is NHS Choices, which to be honest, isn't an awful lot more detailed than this poster. I think we can be a lot more specific now, can't we? So diet, we recommend a low-carb diet. We often use the Mediterranean diet because of the literature, but again, essentially you want a low-carb diet full of natural food, high in monounsaturates. You want to avoid sugars, particularly fructose for the reasons we've talked about, and certainly sweetened drinks. The advice is to lose 10% of weight and to maintain that loss, which improves liver histology. I've put brackets around the advice about considering a diet of 600 kilocalories or less, because there is evidence about that, but it's very hard to get patients to calorie count, and I think we often lose their motivation then. It's much easier to talk about real food, avoiding packets, those sorts of things. And there is some evidence around supplementing with fish oils, but then we could just ask them to eat more oily fish, which might be a better thing all round. Exercise, the specific advice that I tend to give, reducing sedentary time and increasing activity reduces steatosis, which is fat deposition in the liver. Aerobic activity is great because it improves insulin sensitivity and skeletal muscle. We give the standard advice of 30 minutes of moderate exercise 5 times a week because that does improve liver blood tests and also reduces fat in the liver. But actually, you can make your exercise aerobic, resistance, or high intensity because they all improve liver fat because exercise is just great for the liver. We always say aim for 10,000 steps a day because people often like having something they can measure, and things such as pedometers and Fitbits and so on are so readily available now. It's quite nice. You can engage with your patient, make it a game, make them increase their numbers. This was an interesting piece of research. We're starting now to study low carbohydrate diet and the liver, and this is a paper that was published earlier this year. So what this showed was there's been a lot of work around reducing calories. Is it the reducing calories that makes a difference to fat in the liver, or is it the low carbohydrate diet? But this study has nicely answered that for a number of obese patients in that it used a low carbohydrate diet where the carbohydrates were less than 10% of the energy consumed, but made it isocaloric. So I think we can answer that question now. And what this particular research has shown is there's a decrease in hepatic lipid formation with downregulation of fatty acid synthesis. It modulates gut bacteria, which is what microbiota are. So we've all got billions of bacteria in our colon, which produce a whole variety of things. Some of them are good, some of them are bad. What this particular low-carbohydrate diet does is it increases folate production, that being folic acid, and we know that that's very good to reduce this oxidative stress we talked about causing further damage in the liver. It increases the cytokines that Peter talked about reduces cytokines at 14 days. So we know that, again, that reduces progression towards more serious liver disease. And all in all, it starts to reverse some of the things which we talked about, making worse in terms of livers 3 and 4. So if we can cut out a lot of the things that are happening here, we should be able to prevent this happening, avoid patients getting as far as cirrhosis with the cancer risk and the serious liver health risks that are associated with that. I'm not going to say too much about this slide, but for anyone who's interested, there is some work around drugs and also bariatric surgery. But again, if you can do it with lifestyle and diet, then clearly that's a better way forward. But again, I'm happy to go through those with anybody if they wish. Just to give me an extra 2 minutes to talk about this. So another condition I manage all the time is reflux. Now, reflux is acid in the esophagus, and it's something we see very commonly in gastroenterology. It's pretty expensive. There's an awful lot of drug spend on acid-reducing drugs. Occurs in 20 to 30% of the population. We know that a number fail to respond to drugs. We know that a number fail to respond at all. A number have incomplete resolution of their symptoms. We know there are risks associated here with ongoing inflammation in the gullet. So you can develop narrowing, you can develop a change in the lining of the gullet, which puts you at risk of adenocarcinoma. And we know that that risk has increased over the last 3 decades. We know that the risk of reflux, I'm sure you, particularly the health coaches, will have seen this. The more obese someone is, the more they'll complain about things like reflux, and certainly the GPs will. We know that excess fat will increase the amount of acidity in your gullet and increase the number of reflux episodes. And we know it's 3 times higher in obese men and 4 times higher in obese women. I first came to this because we did some research around reducing irritable bowel syndrome in patients, and part of our intervention was that they would see a dietitian who would put them on a low FODMAP diet. What this does, this is a paper that we published, and a surprise finding was that as well as patients doing really well in terms of reducing their abdominal pain and their bloating and their bowel frequency, is they all started to get much better in terms of heartburn, nausea, and things we traditionally associate with reflux. And that was a surprise to us. But actually it fits with research that's come out more recently. So this was a study in America looking at women, and we know from this study, which was a dietary intervention study, putting these women onto a low carbohydrate diet, we know that simple carbohydrate intake, particularly sucrose, will predict the likelihood of reflux, because we know that what sugars are doing is they're reducing the pressure in the gullet, which is a little valve that stops acid coming up, and also causing that valve to relax. What sugar also does is causes that valve to relax. We know it increases sugar increases acid production in the stomach. We know that just decreasing calories doesn't make any massive difference, but we know that 6 days after starting this low carbohydrate diet, there was a 44% reduction in symptoms, and we know that all of the women actually decreased them and discontinued their medication 10 weeks after they'd started this diet, and that lasted until the end of the diet. We don't have any longer term data following up these patients, but we can assume that if their symptoms are that much better, then they're going to stay on this diet. So I just wanted to share that at the end, just to explain. And if there's anything anybody wants me to go through afterwards, just come and find me.
Brilliant, thank you, Emma. Just from, again, post-reflection, GP work, the number of patients with raised liver functions, particularly one we measure in Somerset ALT, is just enormous, and we've generally, I know I have, ignored it, because what do you do about it, and there's no drug for it. So that, reflecting on that, and then also reflecting on type 2 diabetic patients. So I've taken through a reversal process. I came across this idea that all their acid symptoms went away, and just made me reflect of this typical patient, overweight, type 2 diabetes, on an anti-acid tablet, and you just do some relatively simple lifestyle change, and this person moves back to being a person that doesn't need all those drugs, body's working the way it should do without symptoms. Really simple stuff.